availability and accessibility. As you see in this particular graph, a large majority of men and women reported that they have never seen a condom. And for most part, condoms were not easy to get. So we had also asked a question on how easily you can get a condom. So this shows very clearly that condoms, though men have slightly a greater proportion of men have reported that they have seen condom and they can easily get condom, a large proportion of women have never seen a condom, or they feel that it is very difficult to get a condom. If you some of the qualitative data that came from this situationalist assessment also indicated that the unmarried women, they often feel very embarrassed to ask the A&M for condoms. And also there are a lot of misconceptions around condom. The men saying that we should be using condoms only with sex workers, and if your sexual partner is looking healthy, you don't have to use condom. Such kind of misconceptions, myths around condom use was very much prevalent in the district, and all this came in our situation assessments. So what is the implication for program design from this kind of information? One, we need to make the condoms more easily available, accessible, acceptable to the community. So the stigma, misconceptions around condom use, as well as difficulty in getting the condoms, should be kind of addressed in our program. From the study of female sex workers, one of the important elements that we kind of came across was the client volume. Because this HIV risk is directly linked to the number of clients that these female sex workers entertain, in Bagalkot we wanted this information to be collected and also use this information for better planning focus for the program. For example, in Bagalkot, in a month there would be about 15,000 interactions between the female sex workers and the client. Now, out of this 15,000 interactions, how many of them are contributed by high volume sex workers? Now, can we say, for example, that out of this 15,000 interactions, what proportion of our sex workers who are high volume, they contribute to this? The study clearly showed that about 66% of the total sex work volume in the district is contributed by high volume sex workers. Here, high volume we mean by those who entertain 10 or more clients a week. So which means that by just focusing our attention efforts to this high volume female sex workers, we will be able to cover a large majority, 66%, 2/3 of all the transactional sex in a particular district. So we also know that this volume itself is related to the age. For example, the younger the sex worker, she is more likely to entertain more clients, a high volume sex worker, and also the brothel based ones. So the typology where the sex work happens, is it at home or a brothel or a street, that also determines this kind of a high volume status. So this kind of information on client volume gave us direction as to how to do this kind of a program. Where do we focus? What kind of focusing, or what target groups, what focus would help us to achieve what kind of outcomes for the project. So this information was very important for the program design. Another piece of evidence that helped us in designing the project was the study of healthcare providers. We did a complete census of all the healthcare providers in Hubli Dharwad Municipal Corporation area, as well as some of the urban and rural areas of Bagalkot. Now, the study covered a lot of areas such as the practices of record keeping by the healthcare providers and the kind of training they ever had on HIV and STI care, especially syndromic case management approach, as well as their understanding of HIV and AIDS and STDs, and when do they refer people for testing, what are the kind of dilemmas that they have in disclosure and things like that. So there is basically a report on the healthcare provider study which we can refer. I just wanted to highlight one point from the study which helped us to design the overall training of the healthcare providers under ICHAP. If you look at this table, basically the percentage of the healthcare providers who see a particular number of STD patients in a month. Now, say for example, of all the 998 healthcare providers that we studied, 50% of them don't see any STD patients. So straight away, we don't have to train any of those people in syndromic case management or on HIV. Our priority should be, somewhere here, which is about 14 plus 4% who see 5 to 25 plus STD patients in a month. And since we have done this is a complete enumeration census. Now this helped us to identify the doctors who see STD patients, high volume doctors, and we can train them in syndromic case management and HIV. And in fact, we repeated this similar exercise in all the other districts in Karnataka, and we designed the whole design of regional resource training centers. The concept of training the doctors in syndromic case approach came up from there basically.
More importantly, evidence-based planning also implies that the project has the evidence to prove and demonstrate the impact that it is seeking to make.
One of the important component of evidence-based programming is the ability to gather evidence to prove or to show or to monitor the changes that have occurred because of the program. Basically the outcomes impact of the program. And how do we kind of demonstrate the utility of all these efforts in terms of the outcomes and impact. And now Bagalkot demonstration project has collected a lot of data on various outputs, program outputs, such as how many people have been referred to VCTC, STI, treatments given, condom distribution, and how many people have been met by the link workers. So all this information which we call as output from the project, we have a lot of data on that. I want to show you the other graph which also shows us the kind of project outcome. If you see October 2002, what was the kind of percentage of participants who have ever seen a condom, and compared that with August and 2004 and March 2005. You see in all the groups for both men and women, married, unmarried, there has been an increase in the proportion who reported that they have seen a condom.
It was clear to us that in absence of intervention, the scenario would have been far more grim. Some inevitable developments were an ever-growing rural epidemic, an unacceptable level of STI prevalence among men and women, multi-partner sex, a fairly widespread norm, coupled with poor access to condom leading to greater risk of contracting HIV and recurring STI.